All right. Let's go ahead and get started. We are very lucky to have the speaker with us again. For those of you who don't know Carmen Rezak is a senior healthcare nurse leader with expertise in maternal child health. Having served the greater Los Angeles area for 30 years, she has worked as a certified women's healthcare nurse practitioner, a perinatal nursing specialist, a director of perinatal services, and a corporate maternal child health project coordinator for AHMC Healthcare. She has been with PACLAC since 2021 and is considered a pioneer in leading hospitals to promote and support breastfeeding. Specifically, she has helped 4 hospitals, including the first one in LA County, to achieve a baby-friendlier designation. Carmen is the past board president for Breastfeed LA and is dedicated to improving the health and well-being of women, infants, and families through quality care, outreach, and advocacy to promote and support breastfeeding and best practices. Carmen received a Master's of Jurisprudence Health Law from Loyola University, Chicago, and a BSN MSN in nursing. In 2017, she co-founded the Asian Pacific Islander Native Hawaiian Breastfeeding Task Force of LA County to improve education and support the cultural needs of breastfeeding Asian American Pacific Islander women. Her other passion is advocating and supporting women and families experiencing perinatal mood, anxiety, and depression. She is very focused on bridging the healthcare disparity gap and helping perinatal healthcare providers learn about the impact of implicit bias, racism, and cultural humility. She is currently completing her Doctor of Nursing practice in Advanced Leadership in Healthcare Specialization. I hope you all enjoy this webinar. Carmen, they are all yours.
Thank you so much, Jennifer, for that lovely introduction. So I'm going to share, if I can share my PowerPoint. I will share my screen. Okay, can everyone see that? Yes?
Yes.
Okay. All right, so I'm gonna do, let's see. Oops. I do this so I can, yeah, because I can't. All right. I'm just trying to start slide.
You can click the top left. It has a little green arrow, a screen with a green arrow.
Oh, green arrow. New share. Oh, no, that wasn't right. I'm sharing the screen, but I'm trying to start.
Yeah, so it's all the way on top. You know where it says auto?
Yeah.
It's on.
It's this. Oh shoot! I just I just lost. Okay, I'm looking for where it says start screen. There's a black bar across, and I'm trying to get rid of that at the top of my screen so I can slide. Okay, here.
There you go.
There we go. Okay, I'm good. Okay, good morning, everyone. Thank you so much for being here. I'm very excited to present this topic, please feel free to ask questions at any time. Put it in the chat. Jennifer can help advocate and let me know. And I hope you enjoy this talk. We're going to be talking about the cesarean section and VBAC, the risk, benefits, complications, and the care of the birthing person and the infant. I have no conflicts, financial conflicts to disclose. Okay, our objectives for today are to provide an overview on cesarean section and vaginal birth after cesarean, the VBAC. We're going to discuss risk, benefits, side effects, complications, alternatives for birthing persons and the neonate. We're going to discuss your postpartum assessment and care. We're going to talk about warning and danger signs, which are really, really important and a big emphasis because we're very focused on the 4th trimester, postpartum going all the way from birth through 1 year, and the issues that can occur with severe morbidity and hopefully avoiding mortality. And we're going to discuss follow-up care with the healthcare provider. which has changed from years ago, where we had a set time, where now we're more flexible and more individualizing the care, so that if someone is a high risk, they would follow up sooner than later. Okay, so, and some of this is very, basic. You're all RN, so please excuse if this seems, too basic for you. I just want to be very clear that, so cesarean section is obviously the surgical delivery of one or more babies through an incision in the birthing person's abdomen and uterus, often performed for a medical indication. The World Health Organization recommends that C-sections be performed only when there is a medical necessity. And it's really important that we try and focus on that, because our C-section rates are still very high and we're trying to bring them down. And so we'll talk about that in more detail. The California Care Quality Collaborative, the CMQCC, I don't know if you're familiar with them. They are up at Stanford. They are the reason that California is really doing so well in our maternal morbidity and mortality compared, and some of our other quality initiatives as compared to the rest of the country. Dr. Elliot Main, who is the medical director, who just recently stepped down and is doing other things up at Stanford. But because we have access to such great data, and probably greater than 95% of the hospitals in California are members of CMQCC, we get real-time data on all these different elements, so that we can do great benchmarking and ways to do quality improvement. And the big focus is really on the NTSV, the nulliparous term singleton vertex cesareans, because this is where we have an opportunity to decrease our overall rates of C-sections. This is a woman who, it's her first pregnancy, she is low risk, and if she ends up having a cesarean section, there's greater than a 95% chance that she will continue to have repeat C-sections if she has future children. So in 2016, CMQCC developed this excellent toolkit called Promoting Vaginal Delivery and Reducing C-sections, unnecessary C-sections. Also, a patient safety bundle was developed from the Council on Patient Safety for Women's Health, and along with the CMQCC toolkit. And then, as I said, the Maternal Data Center, which is part of CMQCC, provides accurate, rapid cycle real-time data. So I hope you're able to go on to CMQCC and to actually look at these toolkits and look at some of the data that you can access. Obviously, if you're part of a particular facility, a hospital, you can access some of the data, or some of the, drill down more so than others. Some may be more generic, but there are great webinars that are recorded, and there's a lot of instruction and education materials on the website. So I strongly suggest that you check it out. And they help track and benchmark, so you can benchmark your hospital versus any the region within the system and within the state. So the long-term benefits really are to deliver consistent care and to provide a safe environment and decrease risk of complications. So we are really focused on decreasing our overall C-section rate. So some of the medical indications for C-section are multiple gestation, twins and beyond, triplets, labor that's not progressing, a breech or an unstable lie, such as a transverse or oblique, maybe shoulder dystocia. You have a macrosomic baby greater than 9 pounds, gets stuck, problems with the placenta or umbilical cord, and I will go into more detail on some of these. A history of a previous C-section with a vertical scar, which puts at higher risk for rupture of the uterine rupture. Severe preeclampsia or eclampsia, where we really need to deliver with very high blood pressure, leading to possible seizures, stabilizing mom, and then doing an emergency C-section. And then again, of course, emergency stat C-section, certainly for if the infant's health is in danger. If we're looking at the fetal tracing, category 3 means, we need to deliver this baby. We need to assess what's going on immediately. And so it may end up with an emergency C-section. And then any other chronic conditions, such as diabetes, maybe renal disease, cardiac disease, and any other things that impact the birthing person. The rate of C-section in this country right now, in 2015, 32% of all births were delivered by C-section, and that was the lowest rate since 2007. And now our average rate is about is 32. It has gone up. I've seen some hospitals, when I do site visits, have had C-section rates as high as 60%. And depending where you live in the country and your facility, and the physicians who are delivering will dictate the type of percentage of C-section. It has gone as high as 72%. The state average right now is 32%. Our national target is 23.6% or less, and that's per the Joint Commission core measure, which is perinatal core measure number 2, which is looking at, again, the NTSV, and that's what we're focused on, this first birth, low-risk mom, to decrease that number of C-sections. Again, labor not progressing, such as labor dystocia, is one of the most common, and reasonable reasons we do a C-section: prolonged first stage or prolonged dilation in the opening, of the cervix, and then prolonged second stage, where timing, we have prolonged timing of pushing with complete cervical dilation. So problems with the placenta, such as covering the opening of the cervix. It can be a reason to do a C-section because we don't want the patient to hemorrhage, and having a placenta previa will increase their risk for bleeding, and depending if it's a partial, marginal, partial, or complete. And then obviously prolapse cord, which is where the loop of the umbilical cord slips through the cervix in front of the baby, and that is a medical emergency. So there are certainly many good reasons why we need to do a C-section. However, there are non-medical indications, and a lot of this has to do with the birthing person's choice. So some birthing persons in some cultures, such as in the Chinese cultures, prefer to have a scheduled C-section, even though there may not be a medical indication, and a vaginal delivery is recommended or is given as an option. In my experience with Chinese culture, especially women that have come over internationally from China, certainly years ago we had a very large influx. It's less now for various reasons, but they wanted to pick the date, align with sort of the stars, the moon, and also pick when they wanted their baby as far as year. There are more positive years than others to have a smart and healthy baby. And so those were all considerations. And of course, many physicians would say, well, I want to make sure my patient is satisfied, so I'm going to do the C-section, even though it's not necessarily called for. But it's really, really important that the healthcare provider discuss all the options and promote a shared decision-making between the patient and the healthcare provider, and that we provide informed consent and give all those risks and benefits and complications and alternatives to the patient, so they can really make a good choice for themselves, along with the physician, because obviously the physician is providing the medical has the medical knowledge to share all that information. So it's really important that we, as nurses, understand some of these cultural nuances and specifics with the patients that we care for, because certainly in postpartum, there's certain practices, resting, and they may not be caring for their infant. Maybe they'll have a nanny or a family member taking care of the infant. They may want warm broth. They may not shower for a month. There are lots of different cultural practices that we need to be aware of and understand and respect and incorporate when we're providing our care, and certainly doing these home visits. So regardless of the choice of delivery, unless there is a medical indication, no delivery should occur before 39 weeks gestation to have the most developed infant brain. And you can see this from the March of Dimes. A baby's brain at 35 weeks weighs only 2/3 of what it will weigh at 39 to 40 weeks. So there is a really big difference, and we want to promote that going forward, that we can get as close to term as possible. And, several years ago or longer, we would, the deliveries were at 37, sometimes even 36 weeks. And we consider those late pretermers, but we really want to get to 39 to 40 weeks unless there is a medical indication, because it really does make a difference. Let's see. The preterm birth rate right now is 10.5%. In 2020 currently, and it has gone up 4% in 1 year. In 2011, it was 9.8. So we're going in the wrong direction. And then the United States got a rating from the March of Dimes of D+ overall in preterm birth. California got a B-. And the preterm birth rate for any Black woman is 52% higher than the rate for all other ethnicities. So really important, the infant mortality per 1,000 live births is 10.8 for Black babies versus 4.6 for white babies and 3.8 per Asian baby. So overall, our rate is 5.4% in the United States. In California, it's 3.7. So again, California does a little bit better, but we still have a really long way to go. So it's really important that we're aware of trying to get babies, fetuses to term as long as they're healthy. So when we look at the type of incision that we do for C-sections, there's the abdominal incision is made first, and it either is a horizontal incision, which is like the low transverse made near the pubic hair, and a vertical line between the navel and just above the pubic bone for the vertical incision. The uterine incision is usually horizontal across the lower part of the uterus, a low transverse, and then there are other types depending on the baby's position and complications such as a preterm delivery. So most of the incisions are made like the one on the left, and the one on the right is done if there's an emergency or other various complications, and puts the birthing person at greater risk. So the differences between vertical and horizontal incisions. The horizontal or transverse is the predominant incision, as I said, and it takes longer to access. Sometimes we call it the bikini incision because it's looks nicer than the other, but it can be more bloody. But you're more able to have a trial of labor and a VBAC with the horizontal transverse incision. The vertical incision gives you more rapid access to the uterus. It is, as I said, it can be used in an emergency. Uterine rupture, if you try and have a vaginal delivery. So those that have had a vertical incision are not really candidates for having a VBAC or trial of labor. It also takes longer to heal and is less cosmetically appealing. So the advantages of having a C-section is that it can be scheduled for the convenience and decide when to give birth for both the birthing person and the physician. And that's always nice and convenient. Do not experience the pain of labor. For those that have really great fear of going into labor, this may be an option. However, you do have incisional pain. So that can last a little bit longer and longer recovery time. It can reduce anxiety of waiting for labor to start. It can decrease the risk of incontinence and sexual dysfunction. And it can decrease trauma to the infant by not going through the birth canal. And one of the advantages, again, when we're talking about infection and group B strep, which we screen all women for between 35 and 37 weeks, if the infant, let's say mom was screened negative and then converts to positive, so if the infant going through the birth canal would be at risk for early GBS disease. So that's another advantage. Okay, so the unintended consequences, it puts the neonate at more risk, and also including the risk of hemorrhage, uterine rupture, abnormal placentation, and cardiac events. So because of the rate of vaginal birth after cesarean remains below 15%. So I think I just, wait, let me go back here. I feel like I missed. Okay. I'm trying to find, I'm sorry. I just thought I was out of sync here. So the rate of VBAC remains below 15% in the United States. And the biggest risk of the first cesarean may very well be the likelihood of subsequent cesareans, which is what we're really trying to decrease. The risk of uterine rupture, uterine atony, placenta previa, placenta accreta, surgical adhesions increase with each cesarean section. So that is something to think about. By the third cesarean, the risk of placenta previa nearly triples, and roughly 40% of people with placenta previa will also have placenta accreta. So those are very serious conditions that may require a hysterectomy. Also, the psychological stress, anxiety, and post-traumatic stress disorder has been identified as risks for cesareans. Patients also experience less acute but significant consequences, such as longer hospital stays, increased pain and fatigue, and a slower return to normal activities. So these are sort of the yin and yang of having a C-section, the benefits and some of the drawbacks of going forward with a C-section again. So possible maternal risks from a C-section would be, and these are basic surgical risks, like any risk, the risk for infection, the risk of hemorrhage and blood loss, especially the risk for embolism and blood clots, because as we know, in pregnancy, the woman has more blood circulating, and so it puts her, and because of the change in hormones, it puts her at greater risk for blood clots and embolism. And again, post-op, a C-section, women are not moving around as much, and one of the key things is to get them ambulating and moving around to decrease the risk of blood clots and like a pulmonary embolism, which is very life-threatening. So that's these are significant risks from a C-section. Also, injury to surrounding structures such as the bowel or bladder that can be nicked. The incision might weaken the uterine wall, and the reaction to medication or anesthesia, especially if they're needing general anesthesia. And although most of the anesthesia is not general, but in an emergency, general anesthesia may be used. Most of the anesthesia really is under regional anesthesia, and it numbs only the lower part of the body, and the patient is awake during the procedure. Some choices are the spinal block or the epidural. As I said, a small percentage require general. This may be, especially again in an emergency, having to get the baby out right away, or an emergency such as we have massive bleeding, we may need to do a hysterectomy. And so these would be reasons why we would be offering general anesthesia. Okay, more maternal risks would be abnormalities of the placenta, as I said, in subsequent pregnancies, increased risk of complications like placenta previa, placenta accreta, placenta increta, and placenta percreta, and I'll show you that in the next slide. And uterine rupture, which is the uterus tearing along the scar line if attempting a vag delivery later in a later pregnancy. So ACOG states, the American Congress of OBGYN, choice of C-section is not a good choice for first pregnancy if a woman is planning to have several children. Greater C-sections means greater risk with future pregnancies. and 90% or more risk for repeat C-section with future pregnancies if they have it with the first one. So here's a picture of, you can see what a normal implantation, the placenta with an accreta, an increta, and a percreta. So with a, let's see, usually about a placenta, and then there's a placenta abruption, 1 out of every 100 pregnancies in the 3rd trimester, anytime after 20 weeks gestation. It can lead to fetal growth retardation, IUGR. So when we're looking at the accreta, they're all high-risk complications. So the attachment goes into the uterine wall, into the myometrium. And again, all of these may require, and some definitely do, in hysterectomy because of the bleeding. With an increta, so as I said, the attachment goes into the uterine wall and invades the myometrium. With the increta, the one is the placenta villa invades the myometrium, and the percreta, which is the most severe, the placenta grows through the uterus and can potentially go to nearby organs. So these are all really, really serious conditions that will require a good chance requiring a hysterectomy, unless we can stop, the bleeding. And some of it can be managed, but again, these are all pretty serious conditions for hemorrhage, and so that's really important to understand that. Okay. So let's talk about some of the risks to the infant. So the main risk to the infant from a C-section, apart from fetuses being in a breech presentation, which a lot of times we do a C-section for, unless they have, mom has an external version where they actually manipulate the fetus so that it becomes vertex. Neonates have reaped few benefits from the rising C-section birth rate. Respiratory problems are the main issues, transient tachypnea, difficulty for the fetus to clear, and the newborn to clear the fetal lung fluid. And so with the C-section, then they have greater respiratory distress. As C-section rates increase, though, in recent decades, and cerebral palsy rates have remained unchanged, so that hasn't impacted. Pulmonary hypertension, however, does increase. There's evidence that also indicates that significant health consequences, including the higher rates of serious respiratory complications. There may be surgical injury, such as accidental nicks to the skin, to the infant's skin, that can occur. Also, cesarean birth remains a barrier to early breastfeeding and support. So it may delay the first feeding, and it may interfere with early skin-to-skin contact. I've had experience with patients where the nurses have come to me and said, when I'm making rounds, that this mom in room 10 does not want to breastfeed. And so I've done my due diligence, I provided education, and she still doesn't want to. And so I will go in and I will ask the mom, how are you doing? She's a fresh C-section. And she said, no, I do want to breastfeed, but right now I'm having pain, I'm uncomfortable, and I don't feel like doing it at the moment. And I don't want the baby skin to skin because I don't feel well. So there are lots of reasons that we need to try and ask more questions when we're doing our assessment and individualizing care, and not just assume that mom says, oh, I don't want to breastfeed, and leave it at that. On the converse, I truly believe very much in informed choice. And so mom needs to make that decision for herself, but only after we have done our due diligence and given her enough education and support so that she feels comfortable that she can do it. I mean, there are some moms that know that they want to breastfeed right away and they want to do it immediately and skin to skin. And there are others who think about it, maybe want to do both, maybe don't want to do it at all, and then change their mind. So we can't assume that just because initially mom says one thing, that she's not going to change her mind, or after education or some experience or spending time with her baby, she may want to try it. So again, but with a cesarean birth and we have the incisional pain and discomfort, sometimes breastfeeding gets delayed. The other issue is that because of the respiratory issues to the risk to the infant, there is increased NICU admissions post-op. So these are things to consider. So some of the disadvantages of, as we had already said, was there's a greater than 90% chance that the birthing person will have a repeat C-section if she's had an initial C-section with her first. There's longer hospitalization. There's definitely longer recovery, more discomfort in using stronger pain meds, higher complication rates such as bleeding and infection. And again, as we said, increased risk to the infant and more admissions to the NICU. So postpartum care and assessment. So this is the part where super important. You're going out to the homes at about, I understand, 72 hours. And then a couple of weeks later, if that's correct, and if I'm not correct, please correct me. The things that we want to focus on with the mom is especially is making sure that she is getting plenty of rest. And we want to see if she has any support persons that assisting her as well. Nutrition is extremely important. We want her to have about 300 more calories, especially if she's breastfeeding. We definitely don't want to have heavy lifting. We usually say about the weight of the baby or maybe a little more. Pain relief usually is an ibuprofen or an acetaminophen. For some moms, they may require opioids, and we definitely need to monitor that. And we're very focused on decreasing the risk of any kind of substance use or opioid use disorder. So we're very, very cautious these days on using opioids. Pelvic rest, nothing in the vagina for 6 weeks. No driving for about 1 to 2 weeks, especially if they're taking any stronger pain medications. We want to assess their breastfeeding, and we want to encourage breastfeeding on demand at least 8 times in 24 hours and at least once during the night. If they're formula feeding, we encourage pace bottle feeding, where it's slower. It's also, we recommend the same sort of positioning as we would with breastfeeding, in the sense that we want babies to be facing mom looking into baby's face, having that bonding during that period, whether she's breast or chest feeding or formula feeding. We also want to make sure that she's following up with her healthcare provider at 6 weeks is the standard. However, 1 week post-op, if they need to remove any staples, and if they have a higher risk condition, such as a preeclampsia or other hypertension issues, they may need to be seen within 72 hours. If they've had a hemorrhage or other serious complications, again, 1 to 2 weeks if there are health concerns. Also, if mom's having difficulty with breastfeeding and infant is losing some weight, then again, we want the mom to be able to follow up sooner, especially with the pediatrician for the infant. We also want to recommend some support groups for lactation, because for one, it's great for socialization. Moms can advocate for each other. They bond with each other. They share their trials and tribulations, and it really is a very, very positive experience. And a lot of friendships have developed out of these support groups. And we also want to make sure that we are not forgetting the father, because they are a key role in this. And we want to make sure that they're incorporated and understand their strong role, or their significant other or their partner. We want to make sure that each of them are parts of the care, and that they actually get some of the education, so they can be increased awareness if there's something that any kind of danger signs or warning signs for mom and baby. 40% of postpartum women do not go to their postpartum visit. So the weeks following the birth are really a critical period for a woman and her family. And postpartum now, as I said, the fourth trimester goes up to a year, and it's now covered by Medi-Cal. It is an ongoing process. We want to make sure, especially as I said, any kind of high-risk condition, that the mother is followed up sooner rather than later. And at least by 12 weeks, having a very comprehensive postpartum visit. We also are assessing for PMADs, which we'll talk about in a second. And if there has been a neonatal death, again, we want to make sure that there is support for the family. And then you want to assess sexuality and contraception, because those are also very important issues that a lot of times we don't even address or get into. So let's talk about PMADs, perinatal mood anxiety disorder. It's really, really important to assess for the blues, depression, anxiety. Usually, most women are, after having a baby, experience baby blues for the first 2 weeks, and that really is normal. Very emotional, lots of change in hormones. They're exhausted. They're adjusting to new role. Anxiety is high. It's like, oh my God, this is now the reality. I have this baby. And others take to it very easily, but many of us, I can tell you, I had my first at almost 40, and I was a wreck. I really was a wreck. I remember my husband coming home, and I was crying. The baby was crying. He's going, girls, it was a girl, baby girl. Girls, what's going on? And he took the baby and he was comforting her. And I was just sitting there being a mess. I'm going, I'm a terrible mother. I don't know what I'm doing. I haven't taken a shower. I haven't eaten. All these issues, but it's pretty normal for many of us. But after 2 weeks, we start to delve into more of a depression picture, looking at is the mom eating well? Is she not eating? Does she have any appetite? Noticing more mood swings. Lack of enjoyment in life. She's really not engaged or bonding with her baby. She's not really breastfeeding or chest feeding, or she's doing less. And these are of all are really of great concern, because we want to make sure that we are being proactive. So on your home visit, this is a really important area of focus, especially if the symptoms don't go away and the mom does have trouble caring for her baby, or completing just ADLs and daily tasks. Her hygiene, she may be a mess. She hasn't taken a shower in 2 weeks, or especially if she has any thoughts of harming herself and her baby, which is an immediate, serious, possible crisis. So ACOG recommends postpartum care be ongoing, that we contact the healthcare provider within 3 weeks post-delivery, and we ensure that postpartum evaluation, it's by 12 weeks. It's very key to the health and well-being. And there are moms who absolutely have hurt themselves, killed themselves, and injured and killed their children. So, and that's a postpartum psychosis, which only occurs about 1% of the time. But again, by being proactive and doing a really good assessment with the mom and with her partners and her family, maybe they can provide information for you as well, so that we can be proactive and refer for counseling or provide resources. The Maternal Mental Health Now in Los Angeles County is an excellent resource. If you go on their website, you'll see you can put in per zip code, and you can find out recommendations for counseling for your patients. So the postpartum assessment is vital, and the adjustment to motherhood is key, promoting that family attachment, and there may be a lot of stress. So again, you're assessing for bonding, and assessing for coping skills. How is the mom doing overall? Again, you're assessing, besides psychosocial assessments, environmental assessment. Is the environment safe where the mom is? And does she have food security? And I'll talk about that more in a second as well. So you want to assess their breasts, and certainly if there's any engorgement or cracked nipples, sore, bleeding, you want to address those, because that's really important. And as far as engorgement, if mom is really putting baby to breast, and there's effective latch and attachment. So you want to assess the breastfeeding. Mom should not be getting engorged. So those are some of the issues you want to look out for. Breast to chest feeding. Dads can also provide chest feeding, can do skin to skin. Also, mom can pump, put it in a bottle, and the dad can feed. Can also feed alternative methods such as a spoon or a syringe or even a cup. And those are all things that the partner or dad can do as well, or family member. Again, as I said, lactation support is really important. And so if there's a support group, there's online support groups these days. There's, I know through WIC is a great option to utilize, and I'm sure you're all aware of that. They have a support group online called Cinemoms. It's for Black moms, special support group. So there's really excellent out there. For WIC, all their information is in so many languages, probably any language that of a patient that you're caring for, they have the information. So I highly recommend reaching out to WIC or to your regional breastfeeding liaison at the Public Health WIC or Northeast Valley, depending on the area that you're in. Again, father's involvement or the birthing partner's involvement, really, really important to feel part of all of this. Now assessing the incision, which is probably key. You want to make sure that the incision is intact, that there isn't any redness or swelling, any leaking of fluid, any pus, foul odor coming from the incision or discharge or draining, that the mom doesn't have a fever of anything greater than 100.4. You want to make sure that you're assessing the abdomen and the fundal assessment, the finger breadth above and below the umbilicus. When you're evaluating the incision, make sure it's consistent in color. As the mom is healing, usually goes from red to a more pink color. You want to see if they still have, depending on when you're going out there, if she still has staples or sutures, may have dissolvable sutures. They may have used a type of glue, adhesive glue on the incision. So you're going to assess for all of those things. If she's got steri-strips in place, keep them in place while showering. They will fall off on their own. We don't want them in the hot tub or soaking in the tub and bathing until things are healing. I mean, it's like certainly bathing, but and take a shower, but you don't want to really be immersing in water, especially if there's any issues of infection. You want to make sure that the incision is intact. You want to look for any seromas, which are like swollen lumps that again, you can feel. It can be tender. It can release but you feel pockets of clear serous fluid that may come out. And you want to make sure that the abdomen is not tender. And they're also looking at the outer incision. It can open, it can rupture due to the strain or stress. There may be too much pressure on the abdomen, causing the incision to, or the stitches to loosen or tear. We want to make sure, again, mom's not picking up anything too heavy, or maybe she's climbing lots of stairs, or she's trying to exercise too early. All of these can put a strain on the incision. Sometimes moms are not great healers, especially if you have a diabetic mom, or if a mom is obese, that makes it definitely more difficult for the incision to heal. You may even get to a point where you see necrosis, where there's not enough blood or oxygen to the area, and again, due to infection. And then you've got the necrosis, which is really the worst in that you can see, and will need, some of these need surgical interventions. Certainly the physician needs to assess these things. So these are important areas for the incision. Lots of assessment with the incision, with the abdomen. Again, you're going to look at the lochia. It's going to go from pink to brown in 2 to 6 weeks. Again, you want to make sure there's no heavy bleeding greater than a pad per hour, or if mom's passing lots of clots. again, these are important things to assess for and look out for, and also needs follow-up care if she is. Pain assessment. How is she doing? Is she tolerating? Is she just taking some Tylenol or Motrin, or is she needing something stronger? And assessing the frequency of pain medication. Again, we're always looking for, if they're doing using any new narcotics, that we want to make sure that mom does not run into trouble with opioid abuse. We're very conscious of that these days. Nutrition, again, we want to make sure she's eating well, that she has food security, that she's not lacking for the proper nutrition, that she's continuing to take her prenatal vitamins. I want to assess bowel and bladder. Is she voiding? Okay. Is she having bowel movements? When was her last bowel movement? Is she having constipation, or she can't even move her bowels at all? That's also very concerning. And then sleep and fatigue. It's really important to get enough sleep. And I know it's very difficult, especially for a first mom, because they're so attentive to their infants, and they want to make sure that their babies are okay, always concerned about, SIDS and SUIDS. So, but we tell mom to try and sleep when her baby is sleeping, or if she's got help at home, utilize that help. Sometimes we think we can do it all. As women, we can just handle it all, but you know what? We're human. We are fallible, and that doesn't make us bad moms. We need to rely on others. If there are others to rely on, sometimes there's not, and then that's certainly more challenging. And we want to maybe provide some support and maybe more frequent home visits if we feel that the mom is not doing so well, or that we can refer her for some counseling or support. These are all really important. And again, PMADs, as we spoke about. And then inspecting the lower extremities. And you want to assess for any kind of clots or possible a PE. So you're going to look at the color, you're going to look at the calf size, compare bilateral. Is there any tenderness? Does it feel warm to the touch? Can you feel pedal pulses? Assessing reflexes. These are all really important. If we're concerned about a PE, is mom experiencing any shortness of breath? Is her heart rate increasing? Is her blood pressure decreasing? Is she feeling chest pain? Is she having increased coughing? All these things are important to assess for with ruling out a PE or a blood clot of some sort. We also want to make sure that she looking out for I'm sorry, my mind was going in another direction, that because post-op women are increased risk for clots and for embolisms. It's really, really important that we want to make sure that she is getting some exercise, in the sense of just walking, ambulating. There are some women who are really in great shape. They've exercised up until the end. They are running, they are walking, they do light weights. So those women, will return to activities sooner than others. But again, initially, we want to make sure that they are taking it slow, that they are not straining themselves, but that they are getting some activity, because if they're going to sit, we're going to have greater risk for the clots and embolism. So really important. And this is a life-threatening situation if to make sure they don't get PEs. Okay. We want to look at social determinants of health. Really important. What is their environment like? Are they safe in the home or where they're living? Are they living in their car? Are they living in a hotel, motel? Inside and outside the home. We want to assess for intimate partner violence or any kind of violence. Certainly substance use in the home. How is the hygiene? How is the home? Is the home clean, or their location? Do they have food security, as I said? Do they understand self-care? And are they taking care of themselves? Infant care. And do they have their follow-up appointments, both the mom and baby? And as we said, those follow-up appointments depend on the situation. If they've had a high-risk delivery, if they've had a traumatic delivery, if there's issues with breastfeeding, if the infant is not gaining weight, if there's issues with hyperbiliary, all those things will dictate, their hypertension will dictate how soon they follow up for their postpartum and pediatric visit. It's really, really important that moms and the family understand the danger signs for mom and infant, but I'm focused especially for mothers. The family members really need to be educated and participate in this care. I know that we give the warning signs at discharge from the hospital, but I think these really need to be renewed, reinforced with the family. And I'm going to show you the next slide, the danger signs. Support in the home. Does mom have any kind of assistance, or is she really doing this all on her own, which certainly makes it difficult? Does she have anyone to reach out to, even by telephone? Again, assessing for any substance use, and then assessing the infant as far as is she feeding, whether it's for breast or formula, is there safety, and then of course safe sleep and SIDS, which we talked about last time, and to assess for that while you're in the home. The environment, smoking, substances, no shared bedding, but rooming in is fine, and all those things. The World Health Organization recommends assessment at 3 days, and then at 1 to 2 weeks, 6 weeks, 10 days to 2 weeks for if having baby blues. So those are important sort of milestones to look for with follow-up. Again, a lot of this is dictated by the physician, but I will tell you, if a mom is breastfeeding, we want her to be seen between 48 to 72 hours post-discharge, and that's per the AAP recommendation, and exclusive breastfeeding for the first 6 months, and then adding complementary foods. So it's important to make sure that we're not at risk, the infant at risk for failure to thrive, or losing too much weight, or becoming jaundice. So again, extra precautions certainly with breastfeeding, to make sure mom is breastfeeding frequently enough, and that the feed is adequate, positioning of the baby, certainly listen for audible swallows, suck, latch, all of the things which you're assessing for when you go to the home. The Joint Commission has come up with a new standard of care, which has become a patient safety goals, and that's on healthcare disparity. And one of the things that they focus on is when patients present to the hospital, that the staff are actually assessing for social determinants of health. So all of these things that we've discussed start initially at the hospital and need to be then continued on into the home visits. Okay, sexuality and contraception. We don't usually touch upon this much in the hospital. Physicians don't always, start contraception and talk about that, but it is really an important area. So it's important to at least engage in the conversation when you're visiting. What are the family's future birth plans? Talk about some birth spacing. What kind of contraceptive use or not use did they have? And then maybe discussing some of their options, like Depo-Provera injection or oral contraception. If it's the combined pill, then we want to wait 3 to 6 weeks, again, to avoid the risk of blood clots after a C-section. There's certainly condoms, vaginal ring, and the IUD can be inserted immediately up until 48 hours after birth, or then again at 4 to 6 weeks after birth. So there are a lot of options, but the most important thing is to truly engage in discussing, and we recommend pelvic rest for the first 6 weeks. That isn't always the case or happens, but then again, you can assess for that when you're visiting and asking these questions. I wanted to talk about the danger signs. So mostly similar to any kind of surgical or any kind of sending mom home. Signs of infection, most important. Red and swollen incision, as we said, pus or leaking discharge from the incision, foul-smelling odor, a fever greater than 100.4, worsening pain, tender abdomen. Other signs can include heavy bleeding or severe worsening pelvic pain and cramping. Again, looking for shortness of breath, chest pain to rule out a PE, pain in the calf or redness and swelling, and headaches that won't go away, and blurred vision, looking for severe preeclampsia. Okay. So a pregnancy loss is also something that is very, very difficult for the family. And though they may have a successful C-section and mom survives, maybe there's an issue with the infant and experiences a neonatal death. So important to make sure that they're following up with their healthcare provider, that they get some emotional support, bereavement counseling, maybe join a support group. There are some people who don't really like support groups and want to grieve on their own, but it's certainly an option. And recommend counseling on any kind of recurrent risk or any future family planning. Really, really, really important. And much of this doesn't occur right away, but during your subsequent visits, it's important to discuss and to assess what the needs are of the mom and the family. So this is a really important document that I love, and it comes from A1. It's called Save Your Life, Get Care for These are the post-birth warning signs. And they divide it into, if you need to call immediately 911 or contact your healthcare provider or go to the ER. So the main ones are the pain in the chest, obstructed breathing or shortness of breath, seizures, or thoughts of hurting yourself or your baby. These are immediate 911, need to get help immediately, and go to the nearest ED. Bleeding, depending on the bleeding, incision that is not healing, red or swollen legs, as we talked about, temp fever, headache that does not get better, even after taking, Tylenol and Motrin, and then some visual changes. So these you need to at least encourage them to contact their healthcare provider, and if not, call 911 or go to the ER. These can save a woman's life. And it's very important that the family is well aware, the partner, the dad, significant other, a grandma, whoever is very closely involved with the care or even lives with your patient. This truly can save a life. And what's really good about it is that if they present to the ER, it helps the ER staff focus on this can be perinatal related, because at the bottom you can see it that I had a baby on, gives the date, and I am having, and what are the signs. And now ER has been incorporated into a lot of education. Again, the Joint Commission, I think it was 2020, had their new standard of care on maternal safety with hemorrhage and severe preeclampsia. So the ED was also the staff, both physicians, advanced practice, and nurses, and support staff on the importance of, if a patient presents, especially with severe preeclampsia, what to look out for. There's also issues of cardiomegaly, that it's not dismissed or it's thought of as just asthma, but that really assess. And then if truly there is some significant hypertension, severe preeclampsia, that they are started according to the new algorithm, whether it's labetalol, and several other medications, and can be immediately started. This is especially true for Black women because they have a greater risk, as we said, for hypertension and severe preeclampsia. And sometimes because of bias, because of racism, because of how women of color are treated, not necessarily the same as all others, they are dismissed, or they're thought of as complaining, or they can tolerate pain better. There are many, many misconceptions and stereotypes, which is really important for us to be aware of our own biases and make sure that that is pushed to the side, and that we treat all people equitably and support the needs of the individual patient. I can't emphasize this enough. I have seen too many situations where women have been dismissed, they end up going home and they end up dying, they end up with severe morbidity, or they end up coming back and ending up being hospitalized for weeks because it was not addressed properly or timely. So I put a big emphasis on post warning signs and education of the mom and the family. And postpartum equity is a very large focus today in our healthcare. We focus on women of color and indigent as to maternal warning signs and symptoms. The postpartum or the fourth trimester, as I said, considered up to 1 year post-delivery. Black women have 3 to 4 times increased risk for maternal mortality and then the infant's preterm delivery. And if you go onto the March of Dimes website, you can look at their report card. You can see the various statistics and differences for by race and ethnicity as well. It's very important that we listen to our patients. And one of the biggest complaints that I've heard from women of color is that they are just not listened to. They are ignored. We don't take the time. And if you've been aware, in LA County, the first 6 months of this year, we have had 3 maternal deaths. Black women due to hemorrhage, due to clots, and one was due to COVID. But we need to listen to our patients. And when they present to the ED, these really are the issues. The number one issue, cardiomegaly, heart disease, really impacts, and we're not always aware when they present. So again, we are really focused on everyone being well educated and focused on the perinatal needs up to a year. But the greatest risk is immediately after delivery, the first 48 hours before they leave, and then the first weeks of postpartum. Also, the CDC has a really great campaign called Hear Her, which is very similar to the post-birth warning signs. And so great information to provide to your patients. Okay, so let's talk about VBACs, vaginal birth after C-section. So a VBAC is the vaginal delivery of a baby after having a previous pregnancy delivered by a C-section. We try and do a trial of labor, a TOLAC, after cesarean, to see how they can, if they're a candidate and if they're able to progress to having a vaginal delivery. The NICHD research shows that among appropriate candidates, there's about a 60 to 75% of all VBACs attempted are successful. So it's a pretty high rate. The key, though, is choosing the appropriate candidates, the experience of the provider, the maternal level of care the facility has that can accommodate a VBAC. A level 1 community hospital or small birthing center may not be able to accommodate, and it puts the facility as well as the healthcare provider in a greater risk. It is a reasonable option for many women. So in the 1900s, in the late 1960s, 70s, 80s, 90s, VBACs were much more popular. They were done at the county all the time. And then starting in around 2000, we decreased decreased performing VBACs because of the litigiousness of malpractice, and physicians were afraid to take those risks. So some women were not even offered the option of a VBAC. So when is a VBAC appropriate? If one has had a prior C-section incision that was a low transverse, the incision on the uterus can be different than the incision on the skin. So we want to hopefully know by some documentation that it was a low transverse. Women who've had no more than 2 previous low transverse C-sections, if they've had greater than 2, they're not really a candidate then for VBAC. Women younger than 35 years have, fewer complications. Obviously, advanced maternal age can be a complication just in general in birth. Better chances if you go into labor on your own as opposed to being induced, because the uterine rupture does increase with induction, as we all know. And then there are some calculators out there that help with some decision making for a VBAC. They're not 100% foolproof, but sometimes they help to sort of predict if the person's going to be a good candidate. ACOG has a great practice bulletin, number 115, and it talks about vaginal birth after previous C-section. So you may want to access that resource, that reference. So some of the benefits of a VBAC, well, you don't have to have surgery. There is lower risk of hemorrhage and infection. There's definitely faster recovery, and the potential to avoid risks of C-section delivery, such as a hysterectomy or a bladder injury, blood transfusion, certainly, or infection. I mean, you can get infection with vaginal delivery as well, certainly, but this is just a higher risk with having a surgical procedure. And so with a VBAC, you decrease some of those risks. So who is not a candidate for a VBAC? It's really, really important that, as I said, for the healthcare provider to screen their patients for VBAC. The previous vertical or classical incision or T-shaped incision, no. Greater risk for uterine rupture, certainly with trial of labor. Labor dystocia, if someone has a slow or difficult labor, they may not be a candidate. Again, multiple C-sections. The change of a successful VBAC decreases with multiple C-sections. So again, we said, 1 to 2, fine. Greater than that, again, many physicians will not offer a VBAC. If the baby is breech, certainly then there can be a procedure, the external version, and not all women are offered that or actually want to do that, and some women rather just have a C-section. But if not, there is that option. If they are breech, chronic diseases such as heart or lung disease increases the risk. Having an especially large baby, especially over 10 pounds, is an increased risk. Going beyond the due date, past 40 weeks. So we say post dates are 42 weeks, but most physicians don't even wait till 42 weeks. They're going to be concerned and want to deliver before 42 weeks as the placenta gets tired and old and isn't as effective. So, and then obesity can be, especially serious morbid obesity, can be a consequence, and so they may not be a candidate for a VBAC. So let's talk about some of the risks for VBAC. So uterine rupture is really the main risk. Tear in the wall in the uterus, a rupture of the C-section scar. It often occurs at the site of the previous C-section. It is potentially dangerous, but it is rare. Less than 1% actually experience a uterine rupture, but you don't want to be the 1%. As a result of a uterine rupture, consequences to the mother, again, blood transfusions, even up to a hysterectomy to control the bleeding. The risk to the baby would be a serious injury or death caused by the decreased blood flow to the baby, anoxia. So something to consider. And then it's very important, though, for women to speak to the physician early in the pregnancy to discuss these risks, options, and the benefits and likelihood of successful VBAC. So this is an important, I would say, consideration is why do some physicians and hospitals don't perform VBACs? I skipped a slide. So I'm sorry. I'm sorry. If labor fails to progress or other issues, you may need a C-section after trying a trial of labor. Most risks associated with C-section after that are similar to those associated with a repeat C-section. Again, uterine rupture, hemorrhage and infection, blood clots, and the need for a hysterectomy. So those are all the risks if, again, labor fails and need to have a C-section. It's just like any other risk for a cesarean section. This, I think, is really an important area. Why some physicians and hospitals don't perform VBACs. So VBACs declined, as I said, in the early 2000s. If a woman becomes pregnant 6 months or less after a C-section, it is best to wait. The recommendation is 18 months from a C-section to if they want to do try a trial of labor and do a VBAC. Many facilities don't have 24-hour anesthesia. It's not okay to say, we'll call them in. They really need to be available in-house in case there's any kind of emergency or complication. OBs should be in-house or readily available on call to respond to the need of if they have to have a C-section. There is a higher liability, and this is a really big one for many physicians, the issue of malpractice and potential for lawsuits, which is why many do not want to even offer a VBAC to their patients. Some physicians are just not as experienced and equipped to handle an emergency C-section. And some physicians are just more conservative in their labor practice, and they just don't want to do VBACs and go there. So if a patient really wants a VBAC and she's a candidate, she's going to have to choose another provider to do that. And then some hospitals themselves fear that they don't have the right facilities in the case of a uterine rupture, and so they don't want to take the risk and liability. And the other is convenience. Faster and easier for a provider to schedule a C-section than to wait for a patient's labor to progress naturally. And that's true with any C-section, especially those that are not scheduled if a woman presents in labor. And sometimes it's just, let's expedite, let's induce, and then induction leads to a C-section many times. So these are some considerations that to think about why we don't do VBACs as much as we can and offer to our patients. Well, VBACs are one of the areas that we look at when you go onto the California hospital site as far as looking at patient safety, where the hospitals are rated for their different departments. There's a maternal child area to look at. One of the things we look at NTSV rates, we look at breastfeeding rates, we look at C-section rates, and we look at VBAC rates. Are they performing any VBACs? And as I said, some places should not be because they do not have the staff, the experience, and the right equipment and 24-hour anesthesia. So the postpartum assessment and care is really very similar to having a normal vaginal delivery. The same assessment is performed after a VBAC. You're looking at bleeding and spotting. We want to avoid heavy lifting, rest and nutrition. We want to assess the perineum for any discomfort, any hematomas, any hemorrhoids. Certainly you want to assess the fundus of it's firm and the bleeding is decreasing. So very typical of a normal vaginal delivery. So that concludes the talk.